Viral hepatitis basically is one of those illnesses which is probably not as well talked about as some of the other conditions, but it's something which is very relevant, especially today when we're going to look at those infections which are associated with blood and blood products, because hepatitis, which is just inflammation of the liver, is caused by two viruses in particular, hepatitis B and hepatitis C, which can be transmitted from an infected individual to a non-infected individual once you receive blood, which is containing one of those two viruses. But there are other viruses in the hepatitis group which can also cause problems, but they don't cause problems because they're not transmitted in blood. So hepatitis A gets very little love, but it is one of those viruses which can cause inflammation of the liver. It's common in our population. About 60% of individuals have been exposed at some point, but it doesn't cause any long-term problems. And this is a good thing because the outcome usually is complete resolution of the condition. When we speak about hepatitis, the liver itself only has a few ways to manifest itself when there's a problem. So as soon as the liver becomes infected or inflamed or injured, there's usually some amount of pain in that area, which is usually on the right side under the rib cage. There may be some swelling there. There's usually some fever. There may be jaundice or yellowing of the eyes. And then depending on the cause, the patient may either progress with scarring of the liver, which can be a problem, or they may resolve, or they may require medication depending on the underlying cause. So the ones that we're going to look at today in terms of a cause of hepatitis, which is inflammation of the liver, we have hepatitis B and hepatitis C. Now, the dreaded complications of hepatitis include cirrhosis and portal hypertension. Cirrhosis is just the end stage of any inflammatory process. So when you have inflammation in the liver, just like when you have injury anywhere in the body at all, you're going to get healing of that area with a scar. And if you get a lot of scars in the liver, then ultimately the function of the liver is going to be lost, and this is what we refer to as cirrhosis. So it's the end stage of a number of conditions which affect the liver. And that's a problem because cirrhosis sets you up for cancer of the liver, and it also sets you up for liver failure. And as you know, with only one liver, if you don't have a liver functioning, you're not going to be able to detoxify the body of the normal waste products, which is one of the major functions of the liver and can lead to liver failure and ultimately death. So preventing the complications of portal hypertension, which basically are esophageal varices, which are these little veins which develop inside the esophagus. So this is looking down into the esophagus at these large veins which are not normally present until you have a high pressure in your portal system as a result of long-standing cirrhosis. Or the complications of ascites here, which is another complication which can be portending a worse prognosis in patients who have chronic liver disease. These are the things that we're trying to prevent when we manage patients who have liver disease. So we're going to focus on the two which are more relevant for today's discussion, hepatitis B and hepatitis C. Look briefly at the epidemiology, look at the diagnosis, how is the diagnosis made, and then touch on treatment to see what is available. So hepatitis B is a DNA virus. Dr. Pate Robertson just went through another type of virus, an RNA virus. But hepatitis B is a DNA virus. It's transmitted through blood and body fluids. So when we speak about transfusion, obviously transfusion is not a new thing. It's been going on since at least the 18th century. So initially we just transfuse animal blood to humans, but that didn't last very long because of all the antibodies contained and a lot of reactions which obviously would not have helped the patient. And then eventually we got around to transfusing human blood to humans. But that was also fraught with complications, including a lot of infections and problems with sterility. And it was not until 1943 that someone actually isolated that there is a virus potentially which could cause liver-related problems associated with blood transfusion. So that was the first time that they recognized that the jaundice which follows after blood transfusion may be related to a liver-specific condition. And then in 1971 was when the hepatitis B virus itself was identified as a specific cause of liver-related conditions. So it's not so long ago that this diagnosis was being made as a problem in patients who are transfused. It's a very common condition. It occurs globally. About 350 million people are affected worldwide with hepatitis B. Most of them are located in the eastern areas of the world, so Asia, Sub-Saharan Africa have very high prevalences of hepatitis B, but it is present in North America, South America, and in the Caribbean region. Our own data, which is from 1994, suggests that there is a hepatitis B prevalence of approximately 1% of the population. So still a significant number of individuals in the island would be walking around with a virus which would put them either at risk for hepatitis or the complications associated with the condition. It does cause problems in terms of the impact on the health system. So the WHO estimated in 2000 that about 785,000 deaths per year from liver failure, all causes, and about 60% of them were attributed to both hepatitis B and C, and other causes like alcohol and drugs and so on would have accounted for about a third of those liver-related deaths. So between them, the viruses cause a number of complications associated with chronic liver disease, and would have to be managed to reduce the burden of these conditions. Hepatitis B presents acutely or chronically. So usually when we see a patient who has a liver problem, we want to know if it's something which just occurred or is it something which has been ongoing for a long time, because that affects how we manage these patients. So if you present with acute hepatitis B, clinically, normally the patient is going to have some fever, malaise, right upper quadrant pain, and jaundice, as we discussed before. So it's pretty easy to recognize when there's an acute problem. When the patient presents with chronic hepatitis B, however, usually the virus has been there for at least 6 months or more, and because of the complications of scarring, they will present with the signs of cirrhosis, which we discussed, like ascites, or they may have bleeding from the varices, or they may present with frank hepatocellular carcinoma. So just like cancer from anywhere, which spreads to the liver, if the cancer starts in the liver itself, that may be the first sign that the person has been walking around with the virus for a number of years. Now, the stage of hepatitis B is something which has been worked out a little more clearly in the last few decades. And we recognize that depending on how you acquired the virus, you may fall into one of 3 categories. Now, if you had vertical transmission, meaning from mother to child, it's more likely that you'll go through the usual stage from immune tolerant to being inactive. So the immune tolerant stage, so let's say your mother had hepatitis B, the baby is born with hepatitis B, then the baby's immune system usually will not react to the virus because it's present at the time when the immune system is being matured, and so that infant, when born, usually has normal liver function tests. So the baby's immune system is tolerating the virus. However, at some stage during childhood, they go through an immune active phase, and this occurs when the immune system recognizes, for whatever reason, that this virus is a foreign thing and starts to try and destroy the liver cells which are infected with the virus. And it's this activity against the infective liver cells which causes the problems associated with viral hepatitis B. The inactive carrier stage usually is a very end-stage type of scenario where after a number of years you can actually burn out the liver, so the immune system now does not have any more liver cells to destroy, and so the patient, when you do your blood testing and so on, seems to have normal liver function tests. It's just that they don't have enough liver tissue left to show anything in your blood. Now, the outcome of hepatitis B depends also on the age that you acquire the virus. So if you acquire the virus when you're a neonate, so just born, quite likely 90% or more of individuals will retain the virus for life. If you acquire the virus when you're an adult, so the older you are when you acquire the virus, is the less likely it is that you will develop chronicity. So less than 5% of adults who acquire hepatitis B, either by transfusion or any other means, will hold on to that virus for a long time, and they will clear the virus spontaneously. So usually the younger you are when you acquire the virus, is the worse your prognosis. So let's say for argument's sake, a 35-year-old male presents with jaundice, which is a typical thing. They may not have an enlarged liver on examination. Blood tests are done, and everyone is familiar with the transaminases, which will portend or signify liver injury. And a diagnosis of viral hepatitis is entertained. It may be drug-induced, it could be autoimmune, but for purposes of discussion, we will look briefly at the serology, which allows you to make a diagnosis of viral hepatitis in this individual. To understand that briefly, just to remind you of the cartoon which represents the hepatitis B virus. So there's an outer envelope core, which is represented by a surface antigen in red here in this diagram. And then the center also shows the enzyme which helps to unravel the DNA, which is a DNA polymerase. And then there's a circular structure here, which is another strand of DNA around the enzyme, and a core antigen. Now, each of these components are important because they help us to diagnose the presence of the virus in the body. So when we're diagnosing hepatitis B, what we're looking for is either the antigen, which is that foreign material that the body sees, or the antibody, which is the response to that antigen. So the first thing which we usually will use as a diagnostic tool is a hepatitis B surface antigen. We can also look for the hepatitis E antigen. The antibodies which respond to these antigens would be the anti-hepatitis B surface antigen antibody. And then there's the antibody to the core, which is an IgM and an IgG. And then there's the antibody to the hepatitis E virus. So if you want to make a diagnosis of hepatitis B active disease, you need to have the surface antigen being present. Once you have the antibody being present, that person is cured, or they've been vaccinated. So individuals who have active disease will have the surface antigen present. You can also measure the antibodies to the core antigen, and if they have an IgM component, then that signifies active disease. If they have an IgG component, it signifies past exposure. The E antigen only suggests that this patient has a virus which is a natural virus and not a mutated virus, and this can also be used as a marker to determine the endpoint for treatment. Another test which is maybe not as widely used in terms of early diagnosis, but has significance in terms of treatment, is a hepatitis B viral load. So just like HIV, when we do viral loads, we also do viral loads for the hepatitis B virus, which helps us to decide what the level of viremia is and the response to treatment. So the first question we usually ask when an individual presents with hepatitis B surface antigen positivity is this acute or is this chronic hepatitis B? We can wait for 6 months and not do anything if the patient gets rid of the surface antigen by themselves, and that suggests obviously that they had an acute problem. And that's the best way of deciding if it's acute or chronic if you don't have any complications. We also decide what the E antigen status is, because we can use this to decide what the prognosis is. Patients who have an E antigen status will spontaneously lose the surface antigen at a rate of less than 1% per year. And this is important because individuals who are E antigen negative don't have that as a marker to be used for seroconversion after treatment. And then the third question which we usually ask is, what is viral load? And there are a few things which we are also asked about occasionally in terms of the management of patients with hepatitis B. Having decided that the person has serology to make the diagnosis, individuals often ask, what is the role of liver biopsy? Whether biopsy is necessary at all in patients who are diagnosed. Well, you can have a normal ALT and still have significant inflammation on biopsy. Or it also means that you can have a biopsy which does not show evidence of inflammation because of sampling error. So there is not a definite need for liver biopsy in patients who present with hepatitis, but it does have a role in deciding treatment in patients who are at the in a range where you are unable to quantify the activity of disease based on clinical parameters. And we're going to look at this just briefly. So in terms of treatment for hepatitis B itself, medication is available, but because of the difficulty with accessibility and the associated side effects associated with treatment, there are usually specific indications which are recognized to help to guide clinicians in terms of selecting treatment. If your ALT level is elevated, usually more than 2 times, that's an indication for treatment. It suggests ongoing inflammation. If your hepatitis B DNA level is more than 20,000, that's also an indication for treatment. If your liver biopsy shows moderate to severe inflammation or significant fibrosis, that's also an indication for treatment. And if the person presents acutely with liver failure or with decompensated cirrhosis, where they have ascites or bleeding or encephalopathy, regardless of what the DNA level is, those individuals also will benefit from treatment. Now, the treatment that we have available is dependent on the stage that the patient presents in. If they present acutely, so if they present in that early 6-month period before you decide the person has chronic hepatitis B, usually antivirals have a limited role in that case. Most patients will be managed supportively with intravenous fluids and allow them to settle and then decide whether they go on to chronicity and then treat them with one of the antivirals. So most medication is reserved for patients who present with chronic hepatitis B. And these antivirals outlined here include lamivudine, which is usually dosed at 100 to 150 milligrams daily, tenofovir, adefovir, entecavir, and pegylated interferon are the agents which we have available to manage this condition. We also need to be mindful of the complications of cirrhosis, which will need to be managed independently as well, including screening for esophageal varices by endoscopy and serial alpha-fetoprotein and ultrasound for hepatocellular carcinoma. The preferred oral treatment at the moment is tenofovir in terms of availability. It is already a part of our local armamentarium in the management of HIV and is available at a dose of 300 milligrams daily. It's a single tablet which the patient usually takes with a very low risk of renal toxicity, so that has to be monitored. Lamivudine, also available easily, but has a very high rate of resistance. So even though patients will respond to lamivudine, usually after 5 years, the resistance rates can be as high as 60 to 70%. So individuals usually are switched over if they develop resistance at that stage. So these are oral agents. Interferon is a subcutaneous agent which is useful for the management of hepatitis B because it has a finite duration of administration versus the oral agents, which usually are lifelong. So if the individual does not want to chance having to go through lifelong therapy, they can be offered interferon therapy. However, because it is associated with significant side effects, including risks of anemia and immune suppression and significant dermatological problems, individuals may not tolerate the course of therapy. It is more effective than the oral agents, however, in spontaneous seroconversion at a more rapid rate. So usually individuals will lose the surface antigen, usually 12% up to 4 years after treatment, and then at an increased rate thereafter. So even though the duration of treatment is only for 1 year, they will continue to have benefits even after stopping the treatment. Once the oral agent is started, the individuals would be monitored by doing 6-monthly checks of the hepatitis B viral DNA level, and this has to be sent overseas as we don't have local testing available. But we look for a 2-log decrease in hepatitis B virus to ensure that the patient is responding adequately and does not need adjustments either to dose or the specific medication itself. Compliance is important. and consider switching to an alternate agent when patients do not respond as described before. Ending treatment usually depends on seroconversion, so looking to see if the patient loses either the E antigen and develops antibodies to the E antigen, or whether they develop antibodies to the surface antigen itself. If they do not seroconvert, however, there's still benefit to keeping people on antivirals even if the virus is there. So the goal of treatment with hepatitis B is not to cure the virus, but to suppress the virus. So once we have viral suppression, we maintain the patient on medication indefinitely, as this reduces the morbidity and mortality associated with portal hypertension and also hepatocellular carcinoma. So those are the goals of hepatitis B therapy. Obviously, we'd prefer to prevent hepatitis B, however, and that's why vaccination is so important. So vaccination for hepatitis B is universal, and the Minister of Health is very instrumental in starting that recently. But at-risk individuals definitely would need to be vaccinated, and these include individuals who've been in contact with someone who has hepatitis B. It is transmitted sexually, so usually once we identify an individual, we go through contact tracing to see if we can identify those who would be at risk. Household contacts are important as well, as it can be transmitted through infected fomites, so toothbrushes, razors, that is an important means of transmission. Medical occupations, so those who are in contact with blood and blood products, so doctors, nurses, medical students, technologists, and other healthcare workers are also at risk and need to be vaccinated. Babies of individuals who are hepatitis B positive, and then those who travel to endemic areas certainly need to be vaccinated. The vaccination is a surface antigen only, so it's not a live vaccine. It's just that component of the virus which allows them to mount a response, and it's given in 3 doses. So the initial dose, and then 4 weeks later, and then at 6 months you get a booster. And usually that is very effective in maintaining high levels of titers against hepatitis B. You can measure the titer to see if there has been successful vaccination, but this is not something which is routinely done, as the vast majority of individuals will have some kind of response which is adequate. Usually the duration of efficacy is up to 20 years, and if there's a concern beyond that, then usually a blood test is done to check for the titer of the antibody to the surface antigen and decide whether revaccination or booster is necessary at that stage. When babies are born, you can prevent them developing hepatitis B very effectively by giving the immune globulin, which is basically that immunoglobulin against hepatitis B, and this is passive immunization, and usually has to be given within 12 to 24 hours of delivery. So it's a planned pregnancy. The mother makes sure she sources the immunoglobulin and has it available at the time of birth, so that the doctor or nurse can administer the immunoglobulin to the baby within 12 hours, and this is effective in preventing transmission in up to 98% of individuals. The baby is also then started with the routine vaccination. It can also be given to contacts, so if for whatever reason an individual was exposed to hepatitis B, either by transfusion, needle stick injury, or sexually, if they present within 24 hours, they are also given passive immunization with the goal of preventing either acute or chronic hepatitis B. Hepatitis C is a little different. It's an RNA virus, and it's a more recent virus, so not that much is known in the general medical community about hepatitis C, especially individuals who completed their training prior to 1990. So looking at hepatitis C, we see that it was developed, it's a little hard to see this from the back, I'm sure, but basically what it's showing here is that hepatitis C was only identified in 1989. So prior to that, the diagnosis was not even made and was only described as a non-A, non-B hepatitis. but it was first isolated as a specific diagnosis in 1989, and still is responsible for approximately 150 million infections worldwide. In terms of screening for blood, hepatitis B, as we said before, the screening started in the 1970s. Hepatitis C, since it was only identified in 1989, the screening only began in 1990 and afterwards. So anyone who received blood prior to 1990 would not even have been tested for hepatitis C. And in fact, this is where the majority of cases of hepatitis C would have come from. So patients who would have been exposed to blood or blood products or surgical procedures prior to 1990 would be the largest cohort of individuals with hepatitis C. It is transmitted also through use of infected needles when patients or individuals receive tattoos or piercings or share intravenous needles, and also can be transmitted sexually and from mother to child. So the similar means of transmission for hepatitis B and C as for HIV, and for that reason they tend to run together. It presents with symptoms just like hepatitis B. The liver, as I said, doesn't have many ways of presenting, so they will have abdominal pain, jaundice. But the thing about hepatitis C is that most patients do not have any symptoms at all. So versus hepatitis B, where the individuals are more likely to present with symptoms, the vast majority of individuals with hepatitis C do not present acutely, so they'll present only with the complications. And this is unfortunate because it means that by the time we present, usually we don't have a lot of medication available to manage the condition, and it becomes more problematic in terms of the long-standing complications of cirrhosis and portal hypertension, which we're trying to prevent. Hepatitis C, like hepatitis B, is primarily a liver condition, but it can affect anywhere in the body. There are a number of systemic conditions or extrahepatic manifestations which people will be mindful of. So the hematological conditions include non-Hodgkin's lymphomas as a result of hepatitis C viral infection. You can have vasculitis affecting the skin. It may affect the kidneys also, so glomerulonephritis or nephrotic syndrome are possibilities. It may also be associated with unmasking diabetes mellitus. It can be associated with uveitis or ocular problems, and may also be associated with other neuromuscular disorders like peripheral neuropathies, arthritis, and generalized weakness. Each of those respond, however, to the treatments which are available for hepatitis C and don't require specific treatment. In terms of diagnosis, the serological profile of hepatitis C is a little different than for hepatitis B, and requires detection of the hepatitis C RNA and the antibody to the hepatitis C virus. Most individuals who have hepatitis C will go on to chronicity, about 85%, and this is in contrast to hepatitis B, where the majority of individuals who present will have evidence of resolution spontaneously. Now, in terms of the prevalence locally, the prevalence of hepatitis C is approximately 0.3%, and this is much lower than hepatitis B, but still leaves us with a significant population of individuals to treat. The diagnosis is considered when patients present for blood transfusion before 1990, if there is a history of relatives who have the virus, individuals who are diagnosed HIV positive, or anyone who presents with abnormal liver function tests should have testing done. Now, hepatitis C antibodies against hepatitis C can be detected by an ELISA method, and then has to be confirmed by recombinant immunoblot assay testing. And these are the tests which are used in conjunction with hepatitis C RNA testing to profile the patients and confirm the diagnosis. There are 6 genotypes to be considered. I'm going to go through the details, but suffice to say that the genotypes are important because they allow us to tailor treatment depending on which genotype the patient presents with. Every patient who presents with hepatitis C should be treated, and so it's important to refer patients rapidly so that we can institute treatment at an appropriate stage. There are a number of terms here which are important when we're managing patients, to focus on sustained virological response, which basically suggests that 6 months after treatment, the patient should be negative for hepatitis C. And this is what we use as a marker to decide if the patient is cured. So as opposed to hepatitis B, hepatitis C is associated with a potential for cure. The medications which we have available for hepatitis C treatment will decide how long we treat the patients for. If they have genotype 1, then usually our treatment armamentarium up until 3 years ago included a 1-year duration, and then for genotypes 2 and 3, a 6-month duration of treatment. However, these medications were not as effective and only accomplished treatment cure in approximately 20 to 30% of patients, and this was not acceptable. And so newer medications were developed and released in 2011, including telaprevir and boceprevir, which were direct acting antivirals, which increased the response to treatment and were allowed patients to have a better outcome. These became available in Jamaica up to a year ago and have been used. However, as you can see here, this guideline from the Infectious Diseases Society of America and the American Association for the Study of Liver Diseases notes that the treatment guidelines for hepatitis C are constantly changing, and by the time you finish reading this slide, the recommendations would have changed already. And that's exactly what happened, basically. So usually when we start to manage patients, then they will come to the office, and in March of this year,
or wonder whether I should seek treatment.
Patients actually came with this video.
I don't want to live with the uncertainties of Hep C.
Or wonder whether I should seek treatment.
I am ready.
Because today, there's Harvoni, a revolutionary treatment for the most common type of chronic hepatitis C. Harvoni is proven to cure up to 99% of patients who've had no prior treatment. It's the one and only cure that's one pill once a day for 12 weeks. Certain patients can be cured with just 8 weeks of Harvoni. With Harvoni, there's no interferon, and there are no complex regimens. Tell your doctor if you have other liver or kidney problems or other medical conditions, and about all the medicines you take, including herbal supplements. Harvoni should not be taken with any medicines containing amiodarone, rifampin, or St. John's wort. It also should not be taken with any other medicine that contains Sovaldi. Side effects may include tiredness and headache.
I am ready to put Hep C behind me.
I am ready to be cured.
Are you ready? Ask your Hep C specialist if Harvoni is right for you.
So patients will have access to the internet and also to the foreign media, and then they will come and ask for specific treatment. And unfortunately, it's not readily available in our market, and even in the markets where it is available, the fixed dose combinations of just one pill once a day for 8 to 12 weeks compares much more favorably than having to take a combination of up to 20 tablets for 48 weeks. But the cost differences are significant, so the course, as described previously, will be approximately $1,000 per day. And this has led to problems not only in our market where it's not available, where we anticipate problems, but in the jurisdictions where it is available in the States and otherwise, the insurance companies are really not looking forward to reimbursing for this condition. So that's about $84,000 for the entire course. However, the drug companies are not without heart, so in some markets, they offer the entire course for $1,000 as opposed to $1,000 per day. And so that's what we're trying to achieve in our market at some stage. The difference is that 94 to 98% of individuals exposed to these medications will be cured of the virus. And so this is why it's becoming very important. It means that individuals who are already on treatment from the older agents, some of them have actually called to see if they can stop treatment and try and wait for these newer medications. And there is a significant pressure to try and get the newer, safer agents on board to see if we can reduce the burden and offer patients a cure. Availability is a problem, as I said, in terms of treatment for hepatitis C. Accessibility, $1,000 per day versus $1,000 for the entire course, US. And then because the time frame for hepatitis C is actually not as long as people may think, the pharmaceutical companies are actually rushing now to try and get their products out to market before they lose this current cohort of hepatitis C patients. So what's happening is that a large number of individuals would have been transfused prior to 1990, but those individuals obviously who were transfused after would have been tested for hepatitis C in terms of blood products. And so the pool of hepatitis C patients is expected to fall significantly in the next 20 years. So there's only about a 20-year period where you can catch most of the individuals who will require these drugs. And so to recover the marketing and development costs, the pharmaceutical companies really have pushed the cost of the medications quite high. The population for hepatitis B and C do exist locally. The thrust should be prevention of spread by identification of the disorder in patients who are symptomatic, but even more so in those who are asymptomatic. Treatment exists for hepatitis B and C, which is something which most people would not be aware of. And all patients should be considered for treatment. It's a public health problem, and follow-up and education are important. So I'll just stop there. Thank you very much.